Thank you everyone for being here. We'll be getting started momentarily. Welcome to Loving Dementia Care, a series of talks sponsored by the UCSF Memory and Aging Center and the San Francisco Institute on Aging. This conference is in its 9th year and is held annually around Valentine's Day, hence the title of the conference and the specific talks. I'm going to review a few housekeeping details before introducing our speakers for today. My name is Catlin Morgan. I'm the Education Manager for Institute on Aging. As you'll see in the chat feature, I've posted these already, but I'll quickly read them. If you have a question for the speaker, please write it in the Q&A section, which you can find by hovering your mouse at the bottom of the screen and then clicking on the Q&A button. We'll have time at the end of today's talk to answer some of those questions. We are providing, as you can see, American Sign Language today. This talk is being recorded and will be available on the MAC and Institute on Aging websites, which I have put into the chat, www.memory.ucsf.edu and www.ioaging.org. At the end of today's talk, we will also put a link to the course evaluation in the chat feature, and we will welcome your constructive feedback. In order to receive continuing education units, participants must complete the evaluation. It takes up to 10 working days to get those out. And if anyone has any questions about this, please feel free to contact me at cmorgan@ioaging.org. If you don't look at the chat today, again, no worries. Everyone's going to get a follow-up email with all the links just mentioned. Now, I would like to introduce today's speakers, and I will make this brief. The first we will have 3 speakers in a row. The first person speaking will be Dr. Julio Rojas of the UCSF Memory and Aging Center. He's a neurologist who specializes in dementia, and he will speak about dementia behavior in a talk called Getting to the Heart of Behavior. After him, we will have 2 speakers speaking to the topic of dementia programming and engagement in a talk called Supporting Independence and Facilitating Engagement by Amanda Dunbar, OTR, over at UCSF MAC, and Alison Moritz, a colleague of mine at Institute on Aging. She's the program director for the Enrichment Center there. And without further ado, I will bow out and we will get started.
Thank you all for being here. It's a pleasure being in this event. I'm going to share some key concepts about managing behaviors in dementia. We also call them neuropsychiatric symptoms of dementia. And the bottom line is that we believe that behaviors are powerful when we use them as a therapeutic intervention. Today, we'll identify how behavioral interventions are a key component for the management of dementia, and we'll discuss a structured approach to introduce these interventions. I can start by saying that sometimes it's disheartening to have a family walk in, coming to our center and hear that another provider, another doctor or someone else caring for them told them that there's nothing to do. They have dementia and that's it. There are no medications, there are no cures. But we believe that there's a lot to do. And we can, by using these behavioral accommodations, behavioral interventions, we can make a big difference in people's lives. So neuropsychiatric symptoms of dementia are very common. Essentially, pretty much everyone with dementia will have at least mild symptoms during the course of the disease. And you can see here in this graph, as the disease progresses, the prevalence of neuropsychiatric symptoms increases too, and especially the prevalence of severe neuropsychiatric symptoms. the number of psychiatric symptoms also increases with as the disease progresses. This is true for dementia in general, but when we look at specific types of dementia like Alzheimer's disease or frontotemporal dementia or traumatic dementia, this also holds true, except that the type of behavioral symptom that is more prevalent in a particular disease changes and varies. This is, for example, coming from a study of about 500 participants, and these are community people, living in the community. Sometimes about 10% that were living alone. So this is representative of what we might expect. This is not just something seen in patients living in assisted living or in memory care units. This is kind of representative of what happens also in the community. So this is an example of what happens in Alzheimer's disease. You can see here the types of behaviors that we think about when we think of difficult behaviors or neuropsychiatric symptoms in dementia. And you can see that the most common symptom in this case is apathy, not to be confused by depression, where it also comes with some feelings of worthlessness, hopelessness. Apathy is just kind of a loss of drive, loss of initiative. But when you actually ask people if they feel depressed, they tell you they feel okay. So it's important to make these distinctions. We pay a lot of attention, to describing, characterizing exactly what people mean by these symptoms. It's not uncommon to hear someone say, "Oh, there's agitation. The patient that's agitated." But we like to go a bit further and try to describe, be more granular around this, and describe if there's aggression, if there's actually anxiety, or this is irritability. You see, there are things that like hallucinations or euphoria that are not as common, but they can happen. And if we were talking, for example, about frontotemporal dementia and not Alzheimer's disease, as in this case, we will be seeing that disinhibition maybe is more prevalent. So it's important to think about what type of dementia we're talking about, what is the cause, because that will create a roadmap for us to plan what sort of things we might be facing with that particular person. So why is behavioral management important? Well, I mentioned this at the beginning. There is no cure, but the goals of treatment remain the same. We want to provide the best possible quality of life despite of the symptoms. And for this, sometimes, you don't even need a degree. You don't need particular credentials to do it. You just need to care about people, right? But if on top of caring, you have a little bit of knowledge, a little bit of training around this, you are in a very good position to make a change, an impact on that family, that diet, patient, caregiver. We want to maximize independence, instrumental functions or daily functions. This is a moving target. So every time we see our patients, we want to make a balance of what neuropsychiatric symptoms we are dealing with and what the level of independence is for that person. And we craft behavioral plans to address those needs and weighting how much independence we are seeing. We also want to enhance whatever cognitive function is there. We want to enhance the behavioral capability, social cognition, ability to relate, and we want to enhance mood. Some of these are enhanced by pharmacological interventions. And this is very important because if we leave this untreated, there are studies showing that there is a correlation with a faster decline in disease. So this is very important. We also want to maximize safety by introducing environmental adaptations and promote social engagement, physical activity as much as possible. Some of this social engagement comes or touches this important issue of preserving personhood. When people have cognitive symptoms or behavioral symptoms, there's a disruption of who that person is, but by managing the behavioral symptoms, we can help restore the sense of who people are, making them feel still part of the community and stay present in who they are as people. So as I mentioned before, if we don't treat behavioral symptoms, and remember these are very common, but if we don't treat the symptoms, there's a lot of stress for the caregivers, could be paid caregivers or not, or just the family members. It's a lot of disruption in the family dynamics when this is happening. Sometimes it can lead to a risk of harm to the patient themselves or the family member who's trying to provide care. And this could, come in the form of psychological harm or physical harm. And definitely there's a reduction in the quality of life. This is most important for the caregiver. As I mentioned before, there's data showing that if symptoms go untreated, there's acceleration of functional decline. And of course, when symptoms are left untreated, then we have this risk of using something that we don't like to use, which is chemical restraint medications to sedate. No one likes to see that picture, but unfortunately, there are circumstances in which we have to use them. And so today we'll talk a little bit about that, how to come up with the triaging method. This is a study that we did here at the Memory and Aging Center when we launched a website with information about dementia. When the study was, or the website was deployed in January, we can see here how many views were seen over time. And you can see that most people were really interested in either medications, but above all, behaviors. There's a lot of interest by caregivers, whoever is dealing with dementia, looking for information about dementia to try to understand behaviors and deal with behaviors. And you can see here the individual page views, behaviors by far exceed everything else. This is also another way of looking at it. The average time that someone spends looking at a particular piece of information in this website, looking at information about behaviors takes us twice as long compared to all the other type of information. So there's a big need outside, right? We know, we sense that the caregivers really want to know. So our job is to empower them, to facilitate this information. The Alzheimer's Association and other professional organizations have proposed that non-pharmacological interventions should be the first line of treatment for neuropsychiatric symptoms. Yet, as professionals, we don't get a lot of training on this. We don't get a lot of theory and not a lot of hands-on training. A lot of this we figure out as providers when we are out. And it's very sad because a lot of the training is tailored towards using medications. And we don't really have a structural or a theoretical framework about how to choose a non-pharmacological intervention and how to deploy it. So this is what we're doing here today. We are trying to maybe give a starter around that. It's very important for us to improve our knowledge around this. So it's important to understand the nature of the symptoms, right? When we have neuropsychiatric symptoms, the way we like to see it is we like to think about an ecosystem, right? Where the patient with dementia is not isolated, but is surrounded by caregivers, professional, or could be the family. And then there is an environment. All those factors determine how the symptoms emerge. So in terms of biological factors, I said before, it's important to think about what type of dementia we're dealing with. The areas affected in the brain will be the substrate for certain types of symptoms to emerge. And I put the big distinction, for example, between Alzheimer's and frontotemporal dementia, where in frontotemporal dementia, we might be able to see more disinhibition, for example. In Alzheimer's disease, we see a lot of apathy. So it's important to think about that. It's also important to know who that person is. This is very important when we talk about the social history. We don't necessarily need to become Freud around our patients, but it's really important to understand the psychosocial environment, who they were, and what are the factors that affected their upbringing, the peak of their professional life, the dynamics, the social dynamics with people that are important in their lives. All those things can give you insights, or can give us insights about the nature of the symptoms, and we can also use them to craft interventions. We can weaponize them to create therapies. And then a very important concept here, a factor, which is the environment. And the environment could be the surrounding. It could also be thought of as the whatever is outside the brain that is still part of the person's body. Meaning, is there anything in the body that could be producing an effect on the brain? And this is mostly, we think about this in terms of metabolic decompensations or systemic disease that could have a toll on brain function. And this is the way I like to explain it. You know, when we think of the normal brain, we think of preserved tissue with all the components that we normally see, especially around language and memory. But look at the dramatic change in volume and the atrophy, the shrinkage that we see when someone has dementia. This brain doesn't have the infrastructure to operate normally. So this brain on the right side is vulnerable to any stressors. So we like to think about this concept where a healthy brain is solidly positioned to endure stress. You can bring all sorts of things, pneumonia, you can get them a medication over the counter with side effects, fatigue, lack of sleep. You can skip a meal. You can be distracted by a lot of information, and still you're going to perform well, right? The balance of cognition is going to remain. But in dementia, this is what happens. Your base for function is going to be very small, and even a small stress or just skipping a meal or delaying a meal for a couple of hours can bring a reduction in cognitive function. That this is what we think of in neurology as acute encephalopathy. So it's very important to determine if our patients are going through this. Not every neuropsychiatric symptom has this as a source, but it's important to identify when it happens because it's treatable. Now, what is this structural framework for the type of interventions that we can introduce? In general, we like to classify them as caregiver-oriented or patient-oriented. Two big groups, right? For the caregiver, and I'm marking here the strategies that have the best evidence for efficacy. So in the caregiver, you want to identify, so you say here, specific problematic stimuli or situations that may elicit disruptive behaviors in which the caregiver is involved. So here, really, the main concept is to try to provide education. Educate the caregiver about the nature of the disease, empower them with tools, empower them with resources, and provide them with psychological support. So it's useful to send caregivers to get some counseling, to get psychotherapy. This is very important. There's good evidence that this makes a big difference. When people know that they have options, when they have they're in control, this makes a big change in their assessment of the situation, their well-being, and their disposition, readiness to help the patient. And then we have person-centered interventions. person-centered interventions can be tailored and non-tailored. So I'm presenting them here as first the person-centered, and we have a number of them. We have tailored activity programs, things that are meaningful for the patient that we craft specifically for them. Needs-driven approaches. Basically, this touches a little bit on what the psychological triggers are for symptoms. For example, if a patient with dementia is constantly thinking about her purse and always thinking about her purse and worried about her purse and anxious about where her purse is, and we understand, well, this is a person that when she was young, she always carried a purse. So it's very important to take that into consideration and what the importance of a purse is in her life and for that particular person, and then we craft a plan based on that. Validation therapy, basically this encourages patients to express feelings, and we provide validation and we facilitate patients expressing what they feel, and we empathize with them. So there's a whole body of literature around this and techniques that they don't have this, as you notice, the same weight in terms of evidence as the other interventions provided here, but they can help. Reminiscence therapy, the fact of knowing that people with Alzheimer's disease, for example, have better access to remote memories, and more recent memories are not as accessible. So we help them reach the old memories. And this is why books with pictures are important, or singing an old song from the old times is important, can mitigate anxiety, can mitigate irritability. And then same thing, this is the simulated presence therapy, audio, videotapes of loved ones or people who could serve as momentary interventions in a moment of agitation or a moment of upset. And then we have person-centered, but they are more generic. So the ones I just mentioned in green, we really need to understand who that person is. But there are other interventions, what I'm calling here sensory stimulation, that are more across the board, and you can just try them, and they're kind of hit and miss. That depending on the moment, they may or may not work. So some people might be distracted by sounds or by smells, or maybe even multi-sensory, right? A massage with spa, with music. Depending on who you are, it may or may not work, and the evidence around this is not as strong as the one that I mentioned. Now, notice here that sometimes the cognitive behavioral therapy, basically counseling, is good for the caregiver, but not necessarily for the patient. I rarely see a patient benefit from psychotherapy. The psychotherapy is more important for the caregiver. So for a patient can actually be taxing because it increases the cognitive demand. So we don't recommend them. We recommend these other approaches. There's some evidence that these interventions work. It's not perfect, and we definitely need more work. There are experts around the world, and it's hard to measure the effectiveness of these interventions in the same way that we measure the effectiveness of drugs, for example, because there are so many other variables that we are not able to control in the typical clinical research that supports drug development. Here we're talking about more phenomenological type of variables, outcome variables, less quantitative, more qualitative. So there's got to be a cultural change about how we study these interventions and how we accept them. And so this is work in progress, but there are studies. Rojas is one of the experts. He's in Australia, and he has done a number of studies, including randomized controlled trials about the effectiveness of these interventions. Laura Gitlin is also an expert, and she's done randomized trials around tailored activities. This is where the best evidence comes from this. But this is the bottom line. Caregiver training and support interventions are the best, and they have some effects on the use of medications, institutionalization, and different measures of caregiver distress and behavioral symptoms. So I'm going to walk you through 10 principles that we think about, and I hope you can take them with you. So the first idea, the first principle is, number one, make sure that the difficult symptom is not triggered by a medical condition. Talk to your doctor and make sure that there's a metabolic screen around it. Number two, use a structured method to assess the symptoms. We adopted in the Memory and Aging Center the DICE method, which was developed by Helen Kales right now in UC Davis. And this is a method that basically takes this DICE for the acronym: describe, investigate, create, and evaluate. Describe the behavior, as I said before, more than agitation. Try to describe a little bit the conditions and the features of the behavior, and then investigate the factors that may be promoting the behavior, and we investigate the three elements of the ecosystem: the patient, the caregiver, and the environment. And then we create a plan. We craft a plan based on what we know about the patient, and we evaluate constantly. Between investigation and create plan, we have this assessment of the level of distress for the caregiver and the risk of harm, because this will dictate whether we move to pharmacological interventions concomitantly or primarily, as opposed to behavioral interventions. If the symptom causes low caregiver distress or low risk for the patient, then we're going to favor non-pharmacological interventions. So this is what I mentioned before: non-pharmacological interventions should be implemented before pharmacological treatments or concomitantly. Number four, our job, as I said before again, is to empower caregivers, educate, connect with resources, coach, reassure. There's a lot of material out there. I'm even providing here a website that can help caregivers find paid caregivers, almost like a dating app, talking about love and dementia care and Valentine's Day. Finding the caregiver that is right for you. A big component of empowering people is trying to understand the profile of the caregiver. What is the relationship between the caregiver and the patient, and describe the traits of that caregiver. Some traits like depression, anxiety, or pessimism in a caregiver are not good for the patient, and may be an obstacle for good caregiving. But if you have a caregiver with positive traits, you might be in a better position. This study shows that when caregivers have negative traits, the disease progresses faster. So this is crucial. It's also very important to know how to identify these caregivers and see if they can be trained, or sometimes the best intervention is really to substitute the caregiver, bring paid caregivers that can take over. A lot of caregivers say that the main problem is lack of choice, but when you give them solutions, when you give them strategies, this lack of choice kind of goes away, and that makes a big difference. Even if you don't improve the symptoms, just focusing on the caregiver and making sure the caregiver feels in control, that makes a big difference sometimes. The communication is very important. I recommend that you spend some time looking at communication techniques, pay attention to the style and content that is used in dementia, and different types of dementia may require different styles and different content. The Alzheimer's Association has great resources, great seminars for training about communication. This is crucial for the one-on-one care. So the communication style and content can be thought of depending on the stage of the dementia. It changes. It's a moving target. Things about style: make eye contact, be sure you have attention. Depending of what psychological triggers you have, you may need to approach the style as in a paternalistic way, maybe sometimes in a more affectionate way, type of a partnership, spouse. And this is important to be able to switch depending on the needs of the patient. So I highly recommend to pay attention to these communication techniques and be well trained in those. Now, use an intervention hierarchy, meaning first focus on your caregiver. Create an alliance with your caregiver, because if you don't have an alliance with a caregiver, you can come up with all the wonderful interventions for your patient, but no one will be there to enact them. So make sure that you have a caregiver ready, you form your team, and then you start addressing things that are easy, low-hanging fruit, change the environment, try to improve things in the surroundings for the patient. And then, yeah, let's introduce specific interventions, as I mentioned before in those that slide that showed the different methods. Choose your method, and sometimes you need to use several, and they're not infallible. You need to do trial and error, and then consider medications, and at the end restraints, which is an intervention by itself, and we can just have a lecture on that. So it's important to think around this hierarchy. Person-centered strategies have the best evidence. Know the person and craft activities that have to do with who that person is. If you try to come up with an activity across the board for every person, it might not be as effective, right? You may be tempted to give music for everyone, but maybe there's someone who doesn't appreciate music as much. Or if you want to give some sort of craft, manual activity, it might not fly for everyone. So it's important to know. And hear what I'm saying, stay creative. And this is what makes dementia treatment so fun, because it really reminds you to stay on your toes and work with your caregivers around this. Finally, become structurally competent. What does this mean? Know your resources, know your community, and know what is available in your community. Know what online resources are available, what goods are good, what providers are around you, speech therapy, occupational therapy, who are your counselors in your community. If you know that, you'll be able to provide that to your caregivers, and it's good to compile them. We have here at the center, we have a list of resources, and you might not know everything, but you can always refer to that resource, and it's something that is in a wiki environment. It can be curated by everyone, right? So everyone who knows that something is useful, they put it there, and someone else knows. So it's a good way of keeping resources available. When available, make sure that you introduce systems level changes to address behaviors. This is one of the things that we're doing here in the memory center, for example. We're not only working one-on-one with patients, but we're doing this type of event where we're trying to reach out to our colleagues and share our experience with them. We have a task force that is focusing on training ourselves, basically, and we have support groups. So engaging the community. Sometimes this requires lobbying at the political level, which is important, talking to the media to portray the stories of our patients, to normalize and eliminate the taboo about behaviors in dementia, very important. And then finally, when there's high risk of harm, there's no monkeying around with non-pharmacological strategies. We have to use medications, and we have to be very bold, and we have to be very careful on how we use them. I think of this as being a surgeon. The surgeon after surgery rounds every day on the patient. Well, same thing. If you're using an antipsychotic medication or a sedative, you have to keep a close eye on your patients. It's not just a matter of I prescribe you and I see you in 3 months and good luck. No, it's something of major importance. So I'm going to stop there. And I want to say thank you again for the opportunity to talk. I'm happy to answer questions.
Thank you, Dr. Rojas. We'll be saving questions until the end, after all 3 speakers have completed their presentations. But thank you for that. And now we would like to move on to Amanda Dunbar, who will then turn the platform over to Alison Moritz. And after that, we will have Q&A. Thank you.
Hi there, my name is Amanda Dunbar. I'm an occupational therapist here at UCSF and have the opportunity to work with the lovely folks at the Memory and Aging Clinic. For those of you who don't know, occupational therapists work with patients in a variety of different settings to facilitate engagement and as much independence as possible in daily activities. So essentially with this population, what we do is something called activity analysis. So we look at a task that somebody would like to do, and we look at all the components it takes to do it. So looking at the whole cognition, specifically memory and attention, someone's physical strength, coordination, sensation, vision. And then based on those factors and assessments, we can kind of find where the breakdown is and then give input to how to modify activities for success. So like Julio said, it's very person-centered. As occupational therapy, we're also a very person-centered occupation, but that's the main thing. So kind of three main key points for activities. The activity should be meaningful to the person. So there's a lot of articles and information out there for activities with people with dementia saying, folding laundry or crossword puzzles. But if that's something they've never done before, it might not be the best activity for that person. So you want it to be meaningful, something to get that buy-in to engage them. The next one, simplifying the environment. So during any task, kind of removing any extraneous information. So whether that's physical clutter or noise, like background noise from the TV, kind of turn that off if somebody's trying to focus, just kind of limit the amount of distractions and input. The third thing with any activity is trying to keep in a daily routine as much as possible. So that means performing the activity in the normal place it would be. So doing your self-care items, whether in the bedroom or the bathroom, and kind of doing, like if we were doing a craft activity out in like a living room, kitchen area where it would normally occur. Like Julio said, there's a lot of behaviors, and not to kind of boil it down to like agitation, but that's a common behavior you'll observe if a patient or client is getting frustrated with an activity, if it's too challenging. So in that moment, there are three things, kind of tips you can do. So for that, one, I would start with cueing. So what that means is just kind of how you can help guide your loved one through the task. So the least amount of support would be a verbal cue. So let's use the example of completing a puzzle. They're completing the puzzle, they're looking for a blue piece of the sky. You can say, okay, do you see the blue piece? They acknowledge, okay, I think it's over on the left. So just kind of giving them that cue to look to the left side. If that's not working, you can kind of show them and guide them with your hand and kind of point like, okay, the blue piece is over here, and then showing them in that direction. If they're still not quite getting that, you can kind of help guide their hand over to where they need to be. And then the next level of cueing would be kind of more full physical assist to complete the task. Another option, so that was one, is just kind of how you're cueing and talking to your loved one. The second one is two choices. If somebody's frustrated, you're trying to find a solution, you can offer kind of A and B and have them choose which way to go. A lot of times you don't realize how multi-step tasks are in and of itself. So one thing you can do is really break down components of a task to one step at a time. So for example, even something as basic as brushing your teeth, if you think about it, you have to retrieve your items, you turn on the water, you put the toothpaste on the brush, you brush your teeth, you rinse, you spit, wipe your face, just how many things you have to do. So if you're just kind of focusing on one, okay, let's put the toothpaste on the toothbrush, and then kind of just do things one at a time, not to overwhelm them as much. As far as, mild dementia and kind of activities to focus on, a lot of times, people are able to do their self-cares and kind of even some things around the house. The focus here is more on using schedules. Like I said, very important to use a schedule to try and just get in daily routine so things become more habitual. And then memory aids. So whether that's using classic like Post-it notes for visual cues around the house, or also using smartphones. There's a ton of different apps that people can use to set reminders, even through the calendar app. And if people have a hard time, say like visually reading things, they can have options for it to be an auditory option where they're hearing it instead of having to read it. So there's a lot of options with that. Getting into more moderate cases of dementia and kind of how to modify activities. The biggest thing is, I'd say, focusing on your ADL, so those activities of daily living. You want somebody to be able to perform as much of the task for as long as possible. I know being a caregiver, you've got a lot going on. There's a lot you're doing in the day. It might be frustrating or it might be easier to be like, okay, I'm just going to do this for you. So I would start with maybe identifying the things that are most important for the person, the loved one, to be able to do on their own. So let's talk about, I'll do like dressing as an example. So for somebody getting dressed, kind of a typical person or just kind of mild impairment may be able to go into their room and dress themselves independently. So that's the first step. Okay, that's the least amount of help. Then the second one, maybe they're having some difficulty locating the item. So I'd organize the closet or space kind of based on the clothing type, or just have maybe one dresser they know to look for, so they're not having to look in multiple places. And then if that's still challenging, you can physically lay out the clothes, so put them out on the bed. And then if they're able to get dressed from there, if that's still a little challenging, sometimes depending on the type of dementia, people will develop a dressing apraxia, meaning they just physically can't figure out, how to move their bodies to get the clothes on or the orientation of the clothing. So there's different tips you can use by marking clothing kind of front and back, using things with less complicated closures. So kind of avoiding maybe zippers and buttons and using things that are more elastic or Velcro for a little bit of ease. So seeing how that works with somebody. If that's still pretty challenging for them to get dressed appropriately, you can try handing them the item, like oriented to how to put it on. So handing them the shirt facing, with the torso towards them and the arms out, see if they can put that on. And then from there, kind of leading into more full assist. So some of that can kind of take some effort, but just if that's something that's important, this, I think a daily activity is a great task to engage somebody in versus maybe just kind of a rote task of, doing the pegs in a hole or cones or like that. This is something that's meaningful, this person maintaining the independence. So another example, so somebody's having more of a decline and they were very involved in mealtime. So whether that's preparing the meal or always doing the dishes, you can break it up. Like I said, everything can be broken up into smaller tasks. So if you yourself are cooking, preparing something, you can give them something to whatever is appropriate for their, their physical skill. If it's something they could chop or open or peel or just kind of separate, something that can just be a part of it. Also, just there's different aspects. If they can't participate in the cooking portion for different reasons or kind of just that safety awareness is a factor, have them set the table, have them help with drying the dishes or put away silverware. So there's still aspects of tasks that people can engage in without having to be responsible for the whole portion. So I'm going to go ahead and hand it off over to Alison.
Hi, everybody. I am so happy to be here. Let me go ahead and start by saying I'm Alison Moritz at the Institute on Aging, and I am so thankful for everything that Amanda and Dr. Rojas brought up because it's so important. And I wanted to touch briefly on some of the approaches on how to engage somebody. Amanda brought up great sort of ideas of activities to do, and we could think about it another step further with some of the things that Dr. Rojas was mentioning, where we get symptoms. Again, it's the behavioral outcome of the disease. So something like apathy, because the caregiver and person with diagnosis relationship is so symbiotic, as they're changing, we are also changing too. So when you see issues of apathy, it's an opportunity for us to then modify how we interpret their joy. They're not going to have the same experiences and sort of visceral interactions as they did before. And so that's where we can sort of modify our understanding and behavior. And a lot of that's part of the validation that was spoken about too. Depression, which was another big behavioral outcome. It's just like we would do. It's getting outside, being in nature, having joyful experiences. This is all about the person-centered approach to what we need as a person to have joy. Sleep disorders are another behavior that we can combat with some engagement approaches. And it's getting sunlight. I know that's not always easy on a foggy San Francisco day, but being outdoors, having fresh air, letting your body initiate a difference between sleeping time and wakeful time. And again, it's been brought up many times, but routine is incredibly important. We want to think about keeping away from things like stimulants and also bright blue TV screen lights in the middle of the evening. And aggression, with the incredible program, the Savvy Caregivers training from the Alzheimer's Association, they have an incredible mantra that says, so what? And I use that all the time with my support groups too. If it's really not going to affect them that negatively, give yourself permission to say, so what? If they don't want to engage in something, so what? All right, so they're gonna not engage with that activity on that time. What works one day might really not work the next day. There's also a big testament to group interactions and a certain level of being challenged and stimulated. And I'm gonna talk about a great program that helps facilitate this in just a moment. But what I do is I use interns from USF, a psychology practicum internship, and they have group sessions for people living with diagnosis. And it is online. It's not as good as in person, but they come with these art activities and music scenarios, and they have a whole lesson plan. And they have chunks of an hour at a time, and they're every day. And just the levels of joy and fun that come out of this is just such a huge testament to how we need that human connection. You'll see grandchildren joining in, caregivers will even come in, even though it's really designed to be respite for them as well. But it's that human connection. It's that, I call it the importance of putting your shoes on in the morning. If you get your shoes on, you've got somewhere to go. That gives this quality and validation to your life. And that is all sort of the undercarriage of these behavioral symptoms that exactly Amanda and Dr. Rojas were talking about. I can quickly share some details about the program I just mentioned called Compania. And it's designed, let me see if I can get it bigger. Sorry, guys. I'll go back to the beginning. It's designed to help not only the person with diagnosis, but really the caregiver. It's your companion, it's your care coach. I mean, these themes have come up throughout this entire conversation, but it is your sort of guiding light. It's like the aurora borealis of support that you need, because a big part of caring for your loved one and engaging them is you being cared for and engaged. And I know we're professionals, we all know this, but it's become more and more important. So things like caregiver support groups, education. With Compania, they actually have a care coach that they can call any day from 7 to 7 and just know that they have this support person. And it's really a safety net to make them know that they can do this. And, it's different talking to friends or colleagues about what's going on when you can have a really deep discussion, say in a support group with somebody that's going through the same thing or something similar to yourself. It's invaluable. It really can be life-saving. And to have someone to walk you through this experience and walk next to you that can be the make it or break it for your success as a caregiver, your professional success as a caregiver, and for the person who's living with a diagnosis, their success. And it's all about quality of life. So and because it was birthed out of COVID times, it's available everywhere. That's the nice thing, it's remote. So as most things are, everyone has access to it now. So without further ado, I'd love to pass the floor back to Catlin and open up for sharing.
Thank you, Alison. And if we could bring Amanda and Julio back. I have a couple of questions. The questions thus far seem to be for, well, there was another one there, it got retracted. So Julio, this one is for you, but I would invite any of you to chime in. This person asks, as there is no cure for the disease, why should a goal be to slow down its progression? So Julio, could you address that?
Yeah, it's an important point, and I have to say I'm not the owner of the ultimate truth. I think this is a question that touches on neuroethical issues, and we as a society need to have a conversation about this. But the point here is very, very crucial. If there's no cure and the quality of life declines with the disease progression, why are we trying to come with interventions that slow down progression? Here, the answer, and I would like to hear what Alison and Amanda have to say about this, but from the medical perspective, the answer, the original answer would be primum non nocere. First, do no harm. We're not trying to modify the course of the disease, but any intervention that we are bringing should provide or should not bring more harm, should not cause suffering. So, okay, we could be hands off and let the disease progress, but if that will come with more suffering for the patient, I think that brings an ethical problem. So I think we need to come up with a balance in a way that we let the disease take its course, but also provide the minimal support to prevent the suffering. So this is my stand, but please, I would like to hear other opinions.
Amanda or Alison?
Yeah, so I think, occupational therapy in general is just all about improving quality of life. So no matter where these patients are, what the progression of their disease is, there's always something that you can improve the quality. So as long as this person is still living and engaging in life, there's something we can do to kind of, adapt to their environment and make it easier. Like they can engage and, they want to.
Exactly. It's about a quality of life. I think we often think of the term palliative care as an end of life. And yes, that is part of having a terminal disease, but it's also the origin of palliative is cloaking, to protect, to sort of serve them still. And that's exactly what we're doing. The disease progresses, but the behaviors can be helped and aided and comforted. And that's a lot about what it is. So there's the disease and then there's the behavioral outcomes. So that's what we are working on.
Right. And in terms of behavioral health, Alison, I'll start with you and then we'll go in reverse order this time. Do any of you have any thoughts on Montessori activities for people with dementia?
Yeah, I love Montessori activities for dementia. There's that whole act of purpose, which has come up before, and tactile experience. I can't say I know too much about Montessori, but from what I do, I think that it's a very great approach. I think it's a great approach.
Yeah, kind of similar to Alison, not as familiar in direct approach for applying Montessori activities, but I know it's kind of more kind of like life-based and purposeful in a lot of their activities. Like Dr. Rojas has mentioned too, there's that tailored activity program, which kind of, that looks at people's, like I said, that activity analysis portion, but kind of being very personal to just the person. So kind of really breaking down what's important to them. But I agree with Alison, anything that you can involve all the senses too would be really helpful. Just one-dimensional.
And Dr. Rojas, do you have any thoughts about that?
I'm sorry, can you repeat the question? I'm responding to another query here. Can you repeat the question, please?
Oh, yes, okay. Someone asked, do you have any thoughts about Montessori activities for people with dementia?
Yeah, so this is kind of in line with the idea of tailored activities brought up by Laura Gitlin. And this is what Amanda described more in detail. We don't have, I think the tailored activities will be the parallel that we see in the advanced dementia. I think it is something that is worth exploring further in terms of scientific research. And I would encourage to, if there's any provider identified in the community, to approach them and to work with them. I think it has potential. Amanda, you have any thoughts about that?
No, I definitely, like I said, I don't have, it's a specific training program that you go through. And for a long time, I think it was just for occupational therapists, but I'm not sure if they've opened it up now to kind of the general public or other providers. But I agree. I think it seems, as far as the research goes, to kind of be one of the best things at helping to manage behaviors.
Thank you.
Another question is about yoga. Who would like to speak about yoga and dementia?
Yoga's great for dementia. It regulates the breathing. It brings you back into your body. I can't say enough about how great I think it is, especially since you're doing it with them and it's not sort of like a really long procedural sort of class. They're moving with you, similar to Tai Chi. Yeah, love it. And there are a lot of professionals that are good with dementia.
Absolutely. There are professionals who are experiencing working with people with cognitive impairment. This comes to what we have, this same idea we have been mentioning, right? Yoga will be great for someone if it comes easy to them. If they have been practicing yoga forever, and if you give them yoga at when they have dementia, it's going to be great. If you're going to make them learn yoga when they've never did it, and maybe the dementia's advanced, that's going to be stressful. That's just going to be cognitively taxing. So it depends on who you are. But in general, yes, anything that has a mind-body connection is probably going to be good.
Amanda, we have a question here. Are you aware of any resources for blind people with dementia?
Yeah, there are a lot of resources. Blanking on the full name, but I believe the Lighthouse. I can try and contact, but there's for low vision or visual impairment, there are a lot of resources out there. I'm blanking on the names right now, but let me think. But I know they do cover as well with like cognitive change.
Lighthouse is good.
Yeah.
The San Francisco Public Library has some good resources too for the vision impaired. And they can send out stories so you don't have to go on site. So it's worth checking the library branches too.
One last question here we have, I think probably a question for Alison. Can you hear me, Alison?
Mm-hmm.
Okay, great. This question is specifically about Campania. Let me just pull it up again. And someone asks, would Campania be more for family members caring for loved ones at home, or professional caregivers like home care aides and assisted living, or both?
It could be for both, but it's really designed for family caregivers. So we're hoping that agencies suggest it for family caregivers because it has benefits for the person living. It is really designed to support the caregiver. Whether they live in the same state or not, it really doesn't matter. But and it's also beneficial for folks who are living in facilities too.
Okay.
That's a long answer.
And Dr. Rojas, one last question actually.
Yes.
Could you speak a little bit more to the use of cannabis with people who have dementia? It's kind of a new thing, so not as many people know about that.
Absolutely, absolutely. And this is something that we think about a lot based on, the recent legalization. The scientific data behind this is not very strong. It's hard to investigate this in the formal ways that we do test other drugs. So we have some concerns about cannabis worsening some of the cognitive symptoms, mostly based on research in teenagers, where processing speed comes down, memory comes down, but it could be great to mitigate anxiety or mitigate restlessness, for example. So we do have patients that empirically use it, the different products. So my recommendation is, if you are willing to try, just let your providers know. Let them know so they factor in case there is any side effect. And if you're trying cannabis products, try one thing at a time. Don't make a lot of changes of drugs or doses at the same time. Just one at a time, so you're able to measure exactly or identify exactly what makes what type of change. Now, in general, my recommendation is to try any sort of unapproved product, ideally in the context of research. So if there's a clinical trial that offers you the medication at no cost for you, and it's actually in a supervised environment, that's really the ideal situation in which we would like to offer these interventions. They're not very pervasive, these trials, but I can tell you there's at least one clinical trial that is about to launch. It's called the Levy trial, and it's part of a consortium of clinical trials in Alzheimer's disease, and it's basically the goal of this trial is to study the effects of cannabis on the neuropsychiatric symptoms of dementia, especially in late stages of dementia. So I can actually share it or type it over here in the chat to just look it up. And if there's any center close to you, I think that will be my way to go around this.
Great. We're going to have to wrap up here, but if all three speakers have some resources to be shared, we can send those out along with the slides to the folks who are listening today. So again, I want to thank all three of you. Thanks to our speakers and audience. We hope you enjoyed the talk. Next week, please join us for a talk focusing on a longitudinal case of compassionate caregiving with members of UCSF Memory and Aging Center, Nat Bui RN and Manur Alam. So thank you again, everybody, for being with us today. If you are looking for continuing education units, those will be forthcoming after you take the evaluation within 10 working days. Anybody want to say any last words before we close today? Alison, Amanda, or Julio?
No, thank you. It's been great speaking with all of you.
Yes, thank you. We're
Thank
part of
you
the
all.
community, fighting the good fight.
Thanks for your expertise. Have a great day, everyone.